Hi, everyone, and welcome to our virtual health series with UC Health. My name is Hannah Parrott, and I'm an event coordinator here with the Highlands Ranch Community Association. We are so excited that you could take your time out of your evening to join us tonight to discuss pain management. We are grateful for UC Health Highlands Ranch Hospital as a community partner and happy to host this wonderful event with their assistance. Before we get started, I want to go over a few housekeeping items. During the webinar, your microphones will be muted. To ask questions, please type them into the Q&A chat box located on the bottom of your screen. This can be also found in the control panel. We will save the questions for the Q&A portion at the end of the event. Our presenter this evening is Dr. V from UC Health. Dr. V is the Director of Pain Management at the Interventional Pain Clinic. And now, without further ado, I'll pass the time off to Dr. V.
All right. Well, good evening, everyone. Thank you for taking time from your lovely snowy evening to join us. My name is Dr. V. This is my name. It's a little bit unpronounceable. I'm the director of the Interventional Pain Clinic at the University of Colorado Hospital. And I'm an associate professor in the Department of Anesthesiology. This is our office phone number if you need to get in touch with us for any reason, see a consult or whatever you need. So there are a lot of topics that I could talk about because I treat pain from head to toe. But I thought I'd focus on the part that's most likely to break down in almost everybody here. And that's the most common cause of kind of daily pain in most people. So by the end of this talk, I hope that you'll have an understanding of what causes back pain, know when there's a serious problem that needs urgent attention, and then have an idea of the range of options available to treat it. And then I'll talk a little bit about the new treatments available for treating back pain primarily. We'll talk a little bit about neck pain as well. I'm actually not able to control. Are you able to scooch forward? Perfect, thank you. So a couple of thought questions. You don't have to know the answer. This is not a test question, but it's something to think about. What percent of asymptomatic, meaning young, healthy people that don't have any symptoms at all, no back pain, nothing, of 20-year-olds have disc degeneration on lumbar spine MRI? When you think about that, is it 5%, 15, 35, 50? Intuitively, what does it feel like? And the word disc degeneration may have shown up in some of your medical histories. Maybe some of you have it. It sounds like a scary word, but some percentage of healthy people that are young also have it. So we'll go through that. And then the next slide. And what percent of people have at least one episode of severe low back pain in their lives? So severe being that you either are seeking medical treatment or taking some medications or something that's debilitating to your life. Is it 25%? Is it half of the population? Is it 100%? Does everybody have it? Is it 80%? You don't have to answer me, but you can think about that. So the answer is 80% of people have severe low back pain in their lives. It's almost a guarantee of the human condition that you're going to have it. I don't even know who these 20% are that don't have it. I'm 38 and I've already had a couple of episodes of severe low back pain to the point that I've had to call out of work from L5-S1 disc degeneration. So it's a very universal part of existence, especially with our new lives, sitting in a chair, not being as active, not being as mobile. This is going to be seen a lot. Most of these episodes resolve within 4 weeks for most people, and about 1% have some very serious cause. And so when you have back pain, it can be pretty debilitating, and your thoughts are always, oh my God, is it that 1% horrible thing? Is it cancer? Do I have a fracture? Do I have something else going on that crosses people's minds? So back pain can be very, very debilitating for that reason. And very rarely is surgery really warranted. So that's very, very reassuring because a lot of people don't want surgery. When do you worry about back pain? So if you had a recent fall or sudden injury to the back, you were lifting something, felt the pop, and then now you can't, move your leg or something, that's pretty serious. If you have a lot of numbness or weakness in the legs, that's new and unusual. That's something to worry about. If you have sudden loss of control with your bowel or bladder, that can be a very serious condition called Aquinas Syndrome. If you had recent weight loss, it can actually be an indication of either a nutritional deficiency, which can show up as back pain, or it could be a very kind of early symptom of cancer. If you take steroids on a regular basis, you can actually have weakened bones and you can have fractures of the spine, which need attention. If you have severe diabetes or any immune condition that can make you more prone to infection, you can actually end up with infections of the spine. And then finally, if you have a history of cancer or osteoporosis, it's very possible that what you're feeling is actually a symptom of the cancer metastasizing to somewhere else, like the spine. So how do you treat conservatively? You stay active, you walk, you move. Heat is a great way when you have acute back pain to help resolve that. But you just have to be a little careful about skin burns. Some people get benefit out of ice, but generally our recommendation is that if you have acute back pain, meaning you just were moving the couch and now you have back pain, it's not anything concerning, but it's pretty debilitating. Heat usually works better than ice. And then, over-the-counter medicines are really all most people need. Naproxen and ibuprofen are going to be much stronger than Tylenol. Generally, Tylenol isn't that helpful for, acute back pain. And then a lot of people go to chiropractic for spinal manipulation. People go to massage. People get benefit from acupuncture, and you can lump all that together as physical therapy. So generally, for most people, this is the most conservative and appropriate way to treat early onset of back pain. So for the rest of this talk, somebody asked, what about CBD? There's studies ongoing. Some people get benefit from it and some people don't. So it can be a part of topical, management. Some people use CBD oil or CBD gummies to get benefit. There's a cannabinoid receptor in our body that seems to have something to do with the pain receptors, pain pathway, but it's not very clear cut. And so technically my answer is going to be that it's not known. But that said, I've had enough people come to me and say, hey, listen, I just have like this acute flare and I took a little CBD oil or gummy and I'm fine. That's okay. As long as it's not heavy with THC, you're not going to have the cognitive effects. So CBD is fine. Topical is also fine. The problem with CBD is that it's expensive and insurance doesn't cover it. So, and I'm actually just going to go through quickly the anatomy of the spine. I think if anybody here has back pain, it's worthwhile to know what it is that you're dealing with. So you have 33 vertebrae total, 7 in the cervical, which kind of holds up your heavy head in the brain and swivels around. Thoracic is mostly just like a support system and then holds the ribs so that you can support all the internal organs. The lumbar takes the brunt of the force. And so it's carrying this huge heavy body. It twists and turns, and everything you do, bending forward, bending back, twisting, turning, sitting up from a standing position, or standing up from a seated position, everything puts lots of pressure on the lumbar discs. And it connects to a relatively immobile structure. So the hip and the sacrum aren't really that mobile. And so all of this pressure gets concentrated right in the lumbar. And so a lot of people have lumbar degeneration. It's very common. And this is what the actual, your back bones look like. And so there's this big, huge thing called the vertebral body. It's very dense and thick. It's like the foundation for that level. And then inside there's a little opening called the foramen or the spinal canal. And what travels through there is the spinal cord. And so if you look, it's kind of like a fortress. There's a huge thing in the front, a huge thing in the back. And what this is defending is really your spinal cord. It's a critical thing for you to be able to function, that, if you fall or hit something, that your spinal cord isn't damaged every time you do that. So there's like a very bony, robust structure that really protects the insides. And then you have a few bony things that I won't go through too much of it, but it's a very intricate and beautiful structure whose main purpose is support kind of bending and twisting, but also to protect your spinal cord. And so you may have heard, facet arthropathy or arthritis of the spine. And so in between each of your back bones, there's a little joint called the facet joint. And so that joint, just like your knee, your hip, can degenerate with time. And so that can become arthritic. And so I'll show you some cross-sectional images. And then, as I mentioned, here's your spinal canal. And if you notice that there's a whole bunch of things that can really push against the spinal canal. These facet joints, if they get big enough, they can actually push against nerve and give you radicular pain or pain going down the legs. You can have disc herniations, and the disc sits right above this, and that acts like a shock absorber between the layers of your backbones. And then you could have a ligament here that gets big, and then that compresses on your spinal cord. So the spinal cord likes to be in this big open space and this nice wide open canal, and anything that pinches up against it or pushes against it really can cause problems. And so that's when a lot of people have pain. For example, if you have spinal stenosis and you know that you have spinal stenosis, most people get benefit from leaning forward at in the mall when walking around with a shopping cart. versus leaning back really causes a lot of pain. And so leaning forward, what you're doing is you're actually opening up the spinal canal more, so your spinal cord and nerves have more room to go. And so leaning forward is helpful for most people with spinal stenosis. So what's actually in there, you have a nice big sac called the dura. Inside there is spinal fluid, and inside there are the nerves. And outside of those, these little openings called the foramen come the nerve roots. And so if your doctor told you that you have spinal stenosis and foraminal stenosis or a pinched nerve, what's happening is that as these nerves are exiting, they're being compressed either by this big facet joint or a disc that's herniated right here, or a ligament here that's gotten big. And so you can have central stenosis or foraminal stenosis. So informally, people will say, I have spinal stenosis, or they'll say, oh, I have pinched nerves. And that's what you're referring to. Either the nerve is pinched or the spinal canal is pinched. And then, as I mentioned, here's the disc. So a lot of people have disc bulges. It's very common. It's not always problematic. Where it causes problems is when it severely compresses either the spinal canal or the nerves. So very, very common to have disc bulges. So if you have an MRI that shows disc bulges, it's not necessarily something to be alarmed about. You don't immediately need surgery. Very, very commonly seen. And this is actually kind of gross, but these are the anatomy pictures of what your spinal cord looks like. It's a very delicate, thin thing. This is intraoperatively for the nerve roots as they exit. And so when people think about the lumbar spine, you're not thinking about the spinal cord, you're actually thinking about the nerve roots. So about L1 or L2, your spinal cord is turned into these little rootlets. Cauda equina is Latin for horse's tail. It's kind of like the individual hairs on a horse's tail. And so most of your lumbar issues are actually, the nerves look like this, not like this big, thick spinal cord. And this is what your x-ray shows. So when you go to the doctor, they may say, you know what, you don't actually need an x-ray right now. So if you're just had the back pain like 2 days ago and nothing is really concerning, nothing bad appears to be happening on your exam, they may just say, you know what, we can just get an x-ray next time. And an x-ray basically shows your bones, that's it. So when we look at x-rays, what we're trying to figure out is, are the disc spaces all collapsed down on each other? Are there fractures? You can actually have a fracture of the vertebral body. You can have a fracture back here in one of the posterior structures. You can have severe disc degeneration. You can have arthritis here that we can see on imaging. And then you can have slippages of your vertebrae or backbones on top of each other. And, again, when you see the reports for these things, for the x-rays and the MRIs, they use a lot of scary medical terminology. And it's just important to remember keep in mind a lot of things are normal. So it's really important to ask your doctor, what's normal? Is this expected? And is this serious? Which of these things is most concerning? And then this is, again, kind of another rehashing of the same thing, which is that you have these backbones with these bodies, the vertebral bodies on top of each other. There's these nice squishy discs, and the discs get less squishy as we age. And so when you're young, they're really watery and squishy and really compressible. But as we get older, they dehydrate more and more. And so they're much more prone to fracturing. And so, staying really active and being as healthy as possible, these are all great things to keep your disc young and healthy. And then if you remember, those nerve roots that came out in the picture kind of vertically is actually coming out right here. So you can imagine that there's a nerve root coming out right here. This disc can push up against it and pinch a nerve. This disc can push up and cause spinal stenosis. And so it's a very three-dimensional thing that's going on. And, your spine doctor, whoever you're seeing, should have a model of, your back, and then you can kind of compare and contrast what you're seeing on images with and this is an MRI. So MRI shows soft tissues. X-rays show bony structures, but they don't show things like discs, nerve roots, ligaments, the spinal fluid, and so on. And so, I'm not going to go through exactly how to read it. There's no need for you to do that. But this does show multiple things in 3 dimensions. And so I can scroll through and cut across from here to here, up and down. And so MRI is very nice for that reason. That said, there's a lot of things called incidentalomas that you find on MRI. So a lot of doctors really don't like to order an MRI unless it's very clear what you're looking for. Because chances are, once you're past the age of 30 or 40, you're going to have a lot of pathology that you'll see. The answer to the first question that I asked is that actually 35%, 37% really, in the studies. So more than 1 out of 3 kids, 20-year-olds that have no symptoms whatsoever, have disc degeneration on MRI. And so you really want to be careful when you get the MRI. And then, a lot of people say, oh, I pulled a muscle when, I was lifting something or whatever. And that is almost certainly the correct diagnosis. And the reason is that you have a lot of muscles in your back, kind of from the deepest layers, kind of building out. You have multiple layers overlapping on top of each other. And all it takes is a little tear in one of these muscles to cause you some pretty debilitating back pain. The reason you have all these muscles is because the spine itself can't support all of the weight and the structures and everything else. It would just break down too fast. And so the job of these muscles is to really prop you up, take off as much weight and pressure off the spine as possible. And so when your doctor sends you to physical therapy and says, oh, hey, work on your back muscles, your core muscles and everything, what they're really saying is take as much pressure off your spine as you humanly can by, strengthening all of these, 80 different muscles that you have going on back here. So this gives you a really nice visual perspective of how complicated your back muscle structures are. It's not just a couple of layers. I mean, there's like layers that are interlocking on top of each other, going from the deepest layers and then kind of going out and out and out. So your back is a very beautiful, like well-constructed thing, but the slightest thing can potentially throw it off. And then, as I mentioned before, 37% of kids, age 20 and above, by the time you're, 70, you're virtually guaranteed to have disc degeneration, disc signal loss, disc bulges. These are all very, very scary terms when you see them on MRI and you don't know, on the report and you don't know what that is. And the other thing, especially in Colorado, people are much more active for much longer than, other parts of the country. You might be 70, but if you're out there doing double blacks and, doing triathlons, you want to feel as good as a 25-year-old, but you can't. It's not physiologically feasible. So we'll give some suggestions on how to do that. But as we have more and more people living longer and longer, we're going to see more and more of these issues. So it's very common to have back pain. It's most of the time not alarming. And so the other thing I want to go through is some of the tests that your doctor is going to do to see what's going on. So as I mentioned before, you could have spinal stenosis, you could have pinched nerves, or you could have arthritis in the back. Those are kind of the most common things. And then the most common thing really is muscle spasms or myofascial pain as a source of pain. And so if you kind of bend your leg and lift it straight up, if you have pain shooting down the leg in one of these nerve distributions that you see on the right, it may just be that you have a pinched nerve. And so you can do this yourself. You don't need a doctor to do this. And it's not 100%, but we have to do it sort of with the rest of the neurological exam. But this gives you an idea, is my pain primarily from a pinched nerve? Or if you sort of bend your back like this guy on the right is doing, and that recreates almost all of your pain. So if any of you play golf and you notice that with certain golf swings, you have pain on one side or the other, it could actually be that the arthritis in those joints that I mentioned earlier could be the source of the pain. And the other common thing that we'll see a lot is SI joints, so between the sacrum or the tailbone and the ilium or the hip bone, there's a nice connection that degrades over time. It's another joint, just like the hip or knee joint. And so the SI joint can be painful. So if you notice that you cannot, cross your legs to tie your shoelaces, it could be that the SI joint is the source of your pain. I'm simplifying a lot of this. There's a lot more, full evaluation to do, but this just gives you an idea of, some of the common things. As I mentioned before, there's some very, very serious things that you do not want to miss as a physician when somebody comes in with back pain. And so the things you don't want to miss are like an infection, so an abscess. If you have somebody that's diabetic, you can actually spontaneously have abscesses if your diabetes is severe enough, or if you're on chronic steroids. If you have a history of cancer and now you have new back pain, you should definitely get that checked out, because it's possible, God forbid, that you have cancer that went to the spine. If you're on blood thinners, it's actually possible to have a spontaneous bleed in the spine, and that can give you some pretty severe back pain, some weakness in the legs. And so it's called a hematoma. That's an acute, very serious surgical problem. And then, as I mentioned, called Aquinas Syndrome. So if you know that you have spinal stenosis and you had a big fall, or you were mountain biking and you fell, and now you have sudden loss of bowel or bladder, then it could be what's called this Aquinas Syndrome, which is another surgical emergency. And then there's some non-red flag things where we're not as worried, but it can be very debilitating pain. And so we want to look into it further. As I mentioned, radiculopathy just means that pain is shooting down the leg. And so most of that is from L5 and S1. And why is that? It's because it's kind of at the bottom where you have this immobile sacral joints, and then all the weight of the rest of the body kind of compressing down. And so all that twisting, turning motion really degrades those joints very early. Spinal stenosis this word neurogenic claudication is what I just described, which is that when you're walking, you have leg pain, and then as soon as you sit down or lean forward, that pain gets better. So that's neurogenic claudication. The facet joints are the names of those joints that can become arthritic in the back of the spine, and that's worse with extension or leaning back. And why do we have degeneration so often? And as I mentioned before, the discs are very squishy and watery, especially when we're young. And as we get older, they become less watery, and so they're more fragile and more breakable. And so over time, what happens is you start having these little fractures and breaks, and the inside part of the—
you gotta listen to this.
The inside part of the disc starts to leak out. And so what happens is you have disc herniation. So some of you may have disc herniations. And the reason that's so painful is the inside of that disc is not meant to come out and touch the nerve roots. It is extremely painful. It's called chemical radiculitis. And so it causes like this chemical soup of just really bad, nasty, inflammatory things that happen. And this happens, like, as I mentioned, in everybody, virtually everybody. We all lose discs, the squishiness, compressiveness as we age. Part of the reason that happens is because the disc actually doesn't have any blood vessels going through there. So what happens is kind of like, I don't even know what the equal comparison would be, but the blood vessels really only come to the edge of the vertebral body, which is right here, this square thing. And what happens at that point is that it kind of sends out like bottles into the ocean. The nutrients and everything kind of get sent in, and you kind of hope that it diffuses into the middle of the disc where it needs to be. So people that smoke, people that have diabetes, people that really don't exercise or don't have any cardiovascular health, that those little tiny blood vessels, this very fragile blood vessel supply, really gets overwhelmed by trying to keep up with, both replenishing the disc and the nutrients that it needs, and also washing away some of the waste products in those discs. And that's why you degenerate. And as I mentioned, the inside of it really is not meant to leak out. It's meant to stay inside. The positions that really put a lot of stress on the discs is primarily leaning forward. So squats and deadlifts can be extremely painful if you have disc pathology. And so if you remember, I mentioned if you're playing golf and you lean back and you're trying to hit like a long drive, and you feel pain kind of in one side or the other, that could be the arthritis and the facet joints. If you have pain that's worse with leaning forward, that's probably your discs. So you might have maybe a disc tear, a disc herniation, and something called Modic changes that I'll show you later that could be causing that. And I don't expect anybody here to be able to read your own MRI or anything, but I want to show you what the words mean that you're seeing on your MRI reports, or that you may see on your MRI reports. These are the discs right here. In between these squares, there's this nice gray surface. So water is gray on this MRI image. And then as discs degenerate, they become less and less watery. And so you can literally see it on MRI, where it goes from this gray to this dark color. And again, it's this used to be a big deal, and surgeons would actually go and fuse and do all kinds of surgeries based off of this finding, but it turns out it's a pretty normal thing. So if you see the word disc desiccation just means drying out. Again, it can be a very normal thing. So that and again, as I mentioned before, if you want to look at your MRI images, it's your images, welcome to do it. But my goal is not to get you to be radiologists. It's really just to show you physically what it looks like. When I say a disc is drier, you can see it on the images. Disc displacements is basically, they're called protrusions, extrusions, or sequestrations, which is when the disc is basically starting to pooch out of its ligament that's holding it in place. And so we'll see that as discs degenerate. In here, you can see this very nicely. You have like this line right here that kind of keeps the discs in place. And then over here, you go, whoop, right there. And so that dark stuff is kind of starting to pooch out. The inside, thankfully, is still in there. So it's not a full herniation. It's just a little protrusion. And then at some point, you'll see this gray stuff kind of coming out. And that's when you know that the inside of the disc is starting to leak out. And that can cause a very bad pain shooting down the legs, typically, is what we see. So those are disc displacements. And you'll see, there's a L4, L5 disc extrusion, or disc extrusion with sequestration, which is basically this where the disc has come out and kind of balled off into a little thing by itself. So it's not even continuous with the disc anymore. These words sound very severe, but they can be very normal. And the disc herniation, as I mentioned before, you can kind of pinch on the spinal cord in the middle, or you can go pinch on the nerve as it's coming out of your backbones. So the radiologists call this in different ways, but basically you want to know, is it pinching in the middle or is it pinching outside where the nerve is coming out? So pinch nerve. As I mentioned before, when you see your MRI, so if it's really profound, your doctor will actually be like, hey, listen, look at this. It's really cool because you can see it. It's very obvious when you look at a normal level versus not. So it's a normal level here, fine, gray disc, nice backbone, no fractures. You come down here, it's a little darker, so maybe a little disc desiccation, and you go, whoa, this huge thing is coming all the way out. And this actually has completely come out all the way. And so this is called superior migration, where the disc has come out and is like moving up. It can have dramatic symptoms, but it can also just be kind of there with like some low-grade irritation. I'm going to skip through this. Again, as I mentioned before, the red flags, one of the big red flags, if you know you have spinal stenosis, your doctor will say, hey, listen, everything's fine. You don't need to do anything right now. But if you have a fall, or if you suddenly get in a car accident and you can't control your bowel bladder, you lose control of bowel bladder, it's very serious. And this is what they're referring to. And what happens there is that basically your sacral nerve roots, S1 on down, those nerve roots are what are controlling your bowel and bladder. And so if you have a big herniation at L5-S1 and you already had tight spinal stenosis anyway, that can be all you need to really compress and basically leave absolutely no room for your sacral nerve roots. And so that can be a surgical emergency. But that's why whenever you go to the doctor, they'll say, oh, are you having any issues with bowel or bladder loss of control? And it's usually pretty profound. It's not subtle. It's not like, oh, hey, I can't make it to the bathroom in time. It's like, oh my God, I don't know what happened, but I looked down and now I've like wet myself or, soiled myself. The facet joints are really problematic because there are these tiny little joints right here, as I mentioned before, that hold your backbones in place as they're twisting in and out of place. And so these joints are tiny, but they're really problematic. So a lot of people have what's called facet arthritis. As I mentioned before, I'm not trying to make you a radiologist or really show you the images, except to show you I can't show you dissections of most people because people don't get dissected for back pain. So MRIs are the best, and CTs are the best way to show this. So here's the facet joint, and this is going to be this exact picture right here. So that joint right there is zoomed in over these images. And so you can see this nice, beautiful parallel lines. It looks really crisp and clean, and it's nice and C-shaped. And as you come down and you start getting more and more arthritis, you start seeing that it's a little more raggedy looking. It's not quite as symmetric and beautiful. And then as you come down even more, you'll see that these joints are actually getting so big that they're pushing up bone on bone against each other. And then when you get really severe down here at the very bottom, the joint is so arthritic and there's so much what's called hypertrophy or bone spurs, you can call them, that they literally go and pinch right up against the nerve root. So this is a nerve root as it's exiting, and this joint is so big that it's pushing up against the nerves. And so this is foraminal stenosis because of all of this arthritis. And the other thing sometimes you'll see that your radiology report will comment on is that there's fluid inside the facet joint, and that's what this looks like. It can be a normal finding, or it can be a pretty serious indication that there's what's called segment instability or movement of one backbone on top of the other. So those are the facet joints. For sure, if you have back pain, you have some component of arthritis in the back. And the best indicator of that is that if you lean back and that recreates a lot of your pain, there's a good likelihood that that's playing a role in it. And then spinal stenosis is another common thing that we'll see. As I mentioned before, there's not one thing that causes spinal stenosis. It's a combination of arthritis in the facet joints kind of pushing up against the nerve roots. Maybe it's a little disc herniation that's pushing up against the spinal canal. Maybe this ligament right here called a ligamentum flavum pushes up, backward and causes this nice, beautiful. If you remember back to that gross anatomy picture I showed you, you saw that there was a nice bag that was holding fluid. And then when you open it up, inside are these nerve roots. And so this is in cross section, kind of like cutting bread slices of those nerve roots. And so you'll see these little dark gray spots, and these are your nerves. So this is what's controlling your ability to walk, sense, do everything. It's these tiny little things on MRI. It's amazing that we can see it. And so there's a nice big bag. And then with spinal stenosis, you notice that here's this ligament right here. This dark thing is pushing up against your nerves. There's a little bit of a disc bulge just pushing inward on the spinal canal. And then these arthritic facet joints right back here are pushing up against the nerve roots. And so you can clearly tell just with one look, this left picture looks nice and open. This right one, clearly something's going on where there's not that nice big white sac of fluid. So that's spinal stenosis. I'm not going to go through this. And then lastly, there's something called instability. So it's called, the formal word is spondylolisthesis. And it's Latin for basically a break with slippage. And so that's what your surgeon means when they say, oh, you have spondylolisthesis or instability of your spine. The best way to know if this is happening is actually if you lean really far forward and really far back on x-rays, you'll see that some of the levels move depending on whether you're doing flexion or extension. And so you might see the words retrolisthesis or anterolisthesis. You'll see this. Instability can be from really traumatic activity. So if you were a gymnast in your youth, or you were a very serious soccer player or basketball player, some kind of contact sport, it's very possible that you had a fracture during one of your contacts and you didn't really know. Or with gymnastics, especially nowadays, these kids are doing this crazy twists and turns. They can have a physical fracture, or you can have what's called degenerative spondylolisthesis. It just happens over time that your facet joints aren't as strong, and there's a lot of pressure as we get more and more degeneration, and it snaps. And it's possible that you wouldn't even know that this happened. So it's called spondylolisthesis. The reason that it's really important is that for a surgeon, this determines if they really need to fuse you. So we'll talk about fusion and everything else, but if you have spondylolisthesis and they have you do the flexion extension films, if it turns out that you have slippage, if you are going to get a surgery, it's very likely that they'll say, actually, you know what, I can't just do a disc replacement or discectomy, I need to actually do a fusion. And on the right is actually a picture of spondylolisthesis. So it's called anterolisthesis. It's actually mild to moderate. And what's happening here is these backbones are lined up nicely next to each other, and you can see a sudden drop off, boom, all the way back here. And so this person probably has degenerative, and they have a little fracture back here called the pars defect or pars fracture. And so what's happening is the entire backbone is shifted forward on top of each other. If you imagine that this takes time, then it develops slowly, and then you won't notice quite as profound symptoms. So it's not like all of a sudden your spinal cord, which runs back here, is just getting slammed against, this bone right here. But if it happens suddenly, you will definitely notice some neurologic symptoms. So you'll have weakness in the legs, probably lose control of bowel bladder. And so spondylolisthesis or slippage of your backbones. And then the other thing, very common in especially women as they get older, past age of 65, you have osteoporosis. You can have vertebral fractures, and it's actually a defining feature for diagnosing osteoporosis. So if you come in with a vertebral fracture, by definition, you have osteoporosis. You don't even need a DEXA, bone scan, nothing. You have osteoporosis until proven otherwise. And the way to prevent this, honestly, is resistance exercises, especially when you're younger. So women in their 40s, 50s, it really behooves you to be up to date. Make sure you're taking calcium, vitamin D, doing resistance exercises. And then the other big thing, which, there's only so much you can control, is trying to avoid falls. And so you can have hip fractures, which a lot of people think about. And people that have hip fractures generally don't do well once they're in their 70s and 80s. And the same is true for vertebral fractures. There's only so much you can do with that. So this is what it looks like. Here are the beautiful backbones, and this is a CT. So it looks different, completely different than an MRI. And a CT is basically just a bunch of X-rays pieced together into a 3D picture. So here's this nice square backbone, squarish backbone, square. And you come up here, and this thing clearly looks different. It's called a wedge fracture. And it's basically this nice bone collapsed on top of each other. It can become pretty severe where these fragments actually go and push up against the spinal cord, and that can become really problematic. And you need to have a surgeon go in, clean it out, do what's called a corpectomy, and potentially kind of prop that up with an artificial joint, basically. As I mentioned, the red flags, we harp on the red flags because as physicians, we do not want to miss this, but this is really rare to see. So what I want you to focus on is not that all of these bad things are possible, but these are the things we worry about. And this is why we ask these questions. Are you on blood thinners? Are you on steroids? Are you diabetic, et cetera, et cetera? Have you recently noticed a sudden increase, sudden loss of weight? It's easy for me to say if you have a lot of back pain to be not worried about this, but this is really rare. So those are the red flags. So what exactly in 2022 can you do with back pain? I'll give you everything. So conservative measures. Physical therapy is my favorite thing to do. The problem is I have a stack of physical therapy exercises in my shelf right now that I should be doing, that I don't. It's really easy to go to physical therapy once or twice. It's really hard to be consistent doing the exercises. I'll tell you the next time I'll be doing it is when I have my next back pain flare. I'll be kind of trying to catch up to the therapy that I should have been doing. Anti-inflammatories, as I mentioned before, naproxen, ibuprofen, things like that, Aleve, Advil are going to be better than Tylenol. There's no real advantage in taking Tylenol. Ice for some people, but generally if it's acute heat. There's these new massagers, which are pretty amazing. They're about $300-400, so it's an investment for sure. They're called Theragun Hypervolt. There's Hyper Ice. But basically what it does is if you have a lot of tight muscles, it's a very percussive massager that you can adjust the speed and settings and everything. But this has been kind of a game changer for, especially if you're athletic. If you're going to be on the slopes and you know you're going to have kind of a tight back or buttock muscles or something, this is really amazing. TENS unit, you can get the TENS 7000 for $20 on Amazon. Some people it works great, some people it doesn't. It's basically an electrical stimulator that sends electrical signals through these contact pads. And what you want when you get a TENS unit is you want to increase the amplitude or the strength of it until you feel the muscles jumping and then turn it down. So it's just below that. You don't want the muscles jumping, that's too painful. And you want to increase the frequency until you feel like a buzzing sensation. And you just leave it on for, whatever time that you want. I typically do like 20 minutes and you have a very pleasant feeling. It just distracts you and everything. But it's not going to be some amazing life-changing thing. Lidocaine topical is now over the counter, 4% topical lidocaine. It's like $15 on Amazon for a box of 10. You can go get it at King Soopers. It can be amazing. It's basically a topical numbing medicine. So topical things only penetrate about 3 to 4 millimeters underneath the skin. So it's really very, you're not going to get the deeper nerves and the joints and everything else. I wouldn't expect that, but it can be really helpful even for deep pathology. Chiropractic is great. It's rare to have a healthcare provider now spend potentially an hour with you, just talking about your issues. And so it can be a really huge benefit. Their manipulations can be very helpful. I put an asterisk there. There's one thing that as a medical, kind of conventional Western medical person, there's one thing that I do not want you to go see a chiropractic for, and that's high velocity adjustments of the neck. There's a very clear demonstration of a risk of what's called carotid artery dissection, high velocity manipulations. And every good chiropractic knows not to do high, or at least like really talk to you about the risks and everything. But it's fantastic for the back. If you find it helpful, I have no objection to you trying it. Rarely does insurance cover it, so it is an out-of-pocket expense for you. But it's actually in multiple society guidelines where we say, spinal manipulation with a chiropractic, if it's helpful to you, no problem. Acupuncture is great on the same issue. A lot of insurances will not cover it. The traditional Chinese explanation of, qi and aligning energies and stuff, we don't fully understand. But what I can tell you for sure is that we have clear evidence that basically it enhances your endogenous opioids. And so it basically boosts up your natural pain relievers. So acupuncture is great. PT exercises, again, as I mentioned, are fantastic. The universal favorites when I talk to a bunch of physical therapists, that what everybody should be doing is at least walking 20 minutes a day. You don't have to go out and run, a 5K, 10K. Just literally walking 20 minutes a day can be some of the best physical therapy you can do. I'll show you some of my favorite exercises that I think most people will benefit from. There's a fantastic website at the University of Michigan, which goes through, which position gives you relief, and then we'll give you some customized exercise based on that. But I think every human being could benefit from a physical therapy evaluation one-on-one where you have an expert spending time with you and looking at what your specific muscle imbalances are and kind of adjusting those. Even if you don't have severe back pain, if you have any issues at all, hip issues, knee, whatever, I think physical therapy is fantastic as a starting point. This is called a clamshell. It works the glutes. And it's a great exercise to strengthen the glutes, which are a big stabilizer of your walking muscles. And then you have a couple of very, very simple exercises. Again, it goes through at the University of Michigan website. The QL stretch is especially useful if you have really tight pain here that radiates into the hip. So the QL is a huge muscle that goes kind of deep in the abdomen all the way and inserts into the hip joint. So again, a one-on-one evaluation is great. I'm gonna talk about what I do very quickly. I do injections, epidurals. Everybody's heard about them. A steroid injection or a cortisol injection into the spine is an epidural. Cortisol is just the name of the medicine. A steroid is the type of medicine. So there's Kenalog, there's dexamethasone, betamethasone, triamcinolone. Depomedrol. And what we're doing is we're basically trying to cover whatever nerve is irritated with some numbing medicine and steroid. There's a couple of ways of doing that. As I mentioned, the nerves come out of the nerve roots, and you can actually go and inject that. That's called a transforaminal. That's when the doctor puts a needle off the sides. And so what they're doing is they're targeting that nerve. So the big thing I tell people is if you have a big pinched nerve and I put a needle right next to it, it's going to hurt for a moment as I get close to it. For some people, it's a miserable experience, and I empathize with them, but it's usually pretty benign. You can just go in the middle and basically inject and cover a bunch of levels if you have multiple things going on. So it's called intralaminar epidural. And then another very common steroid injection is called a facet joint injection, which is when you put a needle into that, remember that facet joint, in that facet joint, if it's arthritic, and inject steroid and numbing medicine there. And then if that doesn't work, you can have what's called a medial branch block. So it's a diagnostic injection, meaning it's not meant to treat whatever the issue is. It's just a diagnostic. So you're blocking these tiny nerves that supply the facet joints. They're called medial branches. And I'm putting a small needle in, putting some numbing medicine. And I usually test you right before I do the injection and right after. And it's that quick. If it's truly coming from these facet joints, you will say, this is the best I've felt in years. If it's anything less than that, it's unlikely to be the source. And if it is a source, I can do what's called an ablation or a burning procedure. So you might have heard, the doctors say, "Oh, I'm going to burn your nerves." What they're talking about is burning these teeny tiny little nerves called the medial branches. You cannot burn those big nerve roots that we showed you earlier with the things that are coming out of those openings, because then you can't walk. So this is an in and out, same day procedure for back pain. So it's an ablation. And then, as I mentioned, the SI joint can be a very common source of pain. We can actually go in and inject that SI joint. We can ablate the nerves that supply the SI joint. And this is a newer technique that I'll talk about very briefly here. It's called an intercept, which is when we go in and burn the nerves, but inside the vertebral body. So the backbone, the square thing that I showed you, has nerve supply in there that we think mediates disc pain. And so when you have discogenic pain or pain from disc degeneration, some people will say, go and replace the disc or go into a fusion, but the outcomes from those are sort of questionable. And so what we've come up with is a way to put a needle directly into the nerve and burn that, which is a same day in and out procedure under general anesthesia. So this is the cutting edge of spine care right now. If you have a fracture, you can actually go in and cement the procedure. It's called vertebroplasty or kyphoplasty. Again, here's the fracture. They're going to go in with needle, put cement in. I'm going to talk very briefly about surgery. So what the surgeons are talking about when they are talking about their approaches. So if you have severe spinal stenosis or disc that's pushing up against your spinal cord, they can actually take a piece of the bone off so that the nerves have room to breathe. So they take off this back part of the lamina called a laminectomy, and they take off the ligament right there so the nerves have more room to maneuver. So it's a laminectomy, usually for a huge disc herniation. Like a laminotomy is when you don't need to take all of the lamina off, you just need to make a little opening. Most people don't get laminotomies, they get laminectomies. And so they also call it a decompression. So if you have severe spinal stenosis, let's say at L4-5 and you get a decompression, they just decompress that lamina. So they take off that piece of bone so your nerves have room to breathe. Foraminotomy is when you have a really tight nerve root or foramen and they just go in and clean that up. Discectomy is when you just have a bulging disc that's pushing up against the nerve root. So surgeon can place a trocar in and basically just eat up, take bites of the disc and kind of pull it out. And there's a risk of what's called reherniation, which is when that ligament is still not intact, and so you can kind of reherniate, and so that risk exists. But discectomy is a relatively simple surgery for the spine surgeons to do these days. A disc replacement is a relatively newer procedure when if you have severe disc degeneration, instead of getting a fusion, you can actually just go in, clean up that old disc that was there and put in a new disc. So it's a disc replacement. It's more commonly done in the neck than in the low back. There are a lot of issues and questions around whether you would be a candidate. So you got to talk to a specific spine surgeon. We have fantastic surgeons that do all of these things at UCHealth. So it's a disc replacement. And the fusion is the thing that most people think about when they think about spine surgery. It's like this hardware, the screws, and then like this crazy, 4 to 6 week rehab process. But to be honest, most people don't really need a fusion. They need one of the simpler surgeries, maybe decompression or discectomy, foraminotomy. And again, the indications are if you have a lot of instability, if you have a lot of weakness in the legs, if you have tumor infection, a bunch of things, but a fusion is a big deal. And a fusion basically just means that you're keeping the bones immobile, so you're keeping it from moving out of place. And so we think that that movement is what's causing pain. And so if you stabilize it, kind of like a knee or a hip that's kind of just moving in and out of place and grinding on each other, if you just hold it in place, then it won't move and it won't cause pain. And so that is what a lot of people think about when they think spine surgery, is these big fusions and like it's going to be so painful and horrible. Most spine surgery is relatively simple. For spine surgery, not for me. So that's something to know. And then the last thing, I actually had a case. This was a talk that I gave to a group of internal medicine and family physician doctors, and just to talk about other things. And so this is actually one of our intracept cases in the OR. This is a young woman, a 55-year-old woman who had severe back pain, had injections, had physical therapy, tried medications and everything else. And she's healthy, active. She just wants to go back skiing, hiking, and all those things. And she didn't want surgery at all. And so she came to us and said, what else can you do? After she said all these other injections. And so we looked at her MRI and we saw these things called Modic Changes, which I think I have a picture of right here. And again, your report may have this and you may see this, which is basically these white spots. It almost looks scary. It looks like cancer or something infiltrating. And it's just a degenerative change and the reaction of the backbones to that. And so that's what we saw on her. And we did this procedure. And the best data we have is that this procedure lasts, more than 5 years, and the vast majority of people get great relief. You can cut down the number of injections you get and everything else. And so this is that little wire that gets released into the backbone, and then we burn those nerves. And so this is the professional society recommendations kind of compiled together. What do you recommend for people with back pain? Exercise. As I mentioned, those discs are really delicate, like these flimsy little arteries and vessels that are doing all the heavy lifting of sending nutrients in and collecting all the wash out. So if you smoke, quit smoking. People will lecture you on smoking and all this stuff, whatever. But in the context of spine, you are 100% accelerating your disc degeneration. So if you need one more incentive to quit smoking, make it that. Healthy body weight, being active, like I mentioned, walking 20 minutes is a fantastic physical therapy exercise. Keeping your core muscle strong and back muscle strong. If you remember back to the picture, you have all of these supporting back muscles, and it takes a lot of effort to kind of keep all of that good and strong. And then yoga is a really fantastic low intensity way to improve back pain. And then this is going to be a little controversial, but I would say minimize the intensity of the weekend warrior activities that you're doing. If you're doing golf, I wouldn't do the full reverse C extension to try to get the longest possible drive. Just go out there and enjoy yourself. So I think as a society, we're a little intense about some of the weekend activity things that we were doing, and we could get better. I talked about a lot. Hopefully I didn't give anybody too much of a headache at all of the complex stuff that we talked about there. This is kind of the standard talk, honestly, that I give patients when you come and see me. I'll go through the MRI. I'll say, this is what this is. I just gave you all of it all at once. So you learned about the spine anatomy. You actually saw some pictures. Hopefully you have an intuitive understanding of why things break down and how, and then what some of the indications are for injections, and what some of the surgeries are. The best way, honestly, is to go see an expert. So if you have issues, come and see me or somebody like me. If you need spine surgery, we'll kind of click you into the right place. We have fantastic surgeons here at the university. And as I mentioned before, the phone number that I gave at the first slide is the best way to get. All you have to do is call and say, hey, I want to schedule with Dr. V or whoever, and we can always get you seen and get you an individualized assessment. So I know I speak fast, I know I covered a lot, but hopefully that was helpful.
Great, thank you, Dr. V. We'll now go ahead and take some questions. I do see we have a few already in the chat. The first question I have for you is, if you received 2 SI joint injections to treat sproliosis, what would be the next steps to treat the pain?
So sacroiliitis, so if those SI joint injections were not helpful at all, and you're sure that it's sacroiliitis, then the next step would actually be to do what's called a radiofrequency ablation. As I showed before, those pictures of the needles where you can burn these tiny nerves, you can do the same thing for the SI joint. A lot of times what happens is that what looks like SI joint is actually not the SI joint at all. It's something else. The problem with the back is, and the reason that this is so hard, even in 2022, with all the stuff we have, sometimes SI joint pathology looks like L5 facet arthritis, which actually looks like L5 radiculopathy, which looks like piriformis syndrome. And so a lot of my time and effort is actually spent trying to figure out what exactly is this? And it's not as straightforward as that. So if you didn't respond and it's truly the SI joint from the sacroiliitis, then the reasonable next step is to do what's called a radiofrequency ablation. It's a simple in and out procedure. It takes about 20 minutes. It can be painful. And so, use a lot of numbing medicine, sometimes get sedation. But the relief from that can be very dramatic, lasting 6 to 12 months or so. But the biggest thing around that question, I would say, is be sure you have an assessment and really make sure that it's truly that SI joint that's causing the pain, because it could be a whole bunch of other imitators that look and act like it.
Great, thank you. And next question, is there any treatment for chronic T-spine muscle knot pain?
Yeah, so the muscle knots that you're referring to are these areas of basically muscle damage, and it's microscopic tears. It's not something you can see on MRI or anything else. And what happens is those muscles start contracting, those little muscle fibers, and there's not enough blood flow going through there. So normally when you pull a muscle or strain a muscle, the blood flow goes through there, all these healing tissue factors go through and repair it. And what happens over time is when you have a knot, it kind of becomes harder and harder to treat, and it becomes a focal source of pain. So if there are any tiny nerves that go through there, you can actually really entrap them and cause a significant amount of pain that doesn't go away. Some people will get benefit from, local massage, local heat, ice, TENS unit, lidocaine, things like that. Physical therapy is great to try to stretch out some of this stuff. Muscle relaxants can be helpful. The problem with muscle relaxants, they go to your brain all over the body and they can have some sedating effects. So you gotta be careful about taking too many muscle relaxants. But in terms of what I do, sometimes once you do all of that, if you still have the pain and I can feel where the knots are and I can push on it and you say, oh my God, that is exactly where the pain is, I actually go in with an ultrasound, look for the knot, go in with a small needle, physically go into that area that's spasming, inject some numbing medicine and steroid and watch it break up. You may have to do 1 or 2 of these treatments, potentially even more, but usually that's very helpful if it's like a very focal knot. So it's called a trigger point injection. Super common, easily done procedure.
Great, thank you. And next question, can you talk about spinal stimulation where there's an electrical impulse sent to the spinal wire?
Yeah, this is one of my main loves in professional life, and I'm super involved with all of this stimulation stuff. And so I'm sorry I didn't put it in there, just in the interest of time. It's a big interest of mine. So the perfect candidate for somebody that is going to benefit from a spinal stimulator is somebody that's already had surgery and still has back pain and leg pain. Burning neuropathic pain is what we call it. And what that stimulator wire does is basically sends electrical signals directly to the spinal cord. And it acts like a really good roadblock where all the painful signals come up and they get confused at the level of spinal cord. And so your brain never gets information. And it is tricking the brain. So whatever the issue was down lower that's causing the problem is still there. But if you don't feel it, then it's not really relevant. And so we'll typically do this in people that have had back surgery and they still have back and leg pain. It's called post-lumbar laminectomy syndrome, or the old term was failed back surgery syndrome. It's a relatively simple procedure. I did 2 this week. And the risks are that it's a lot more invasive than like an epidural or an SI joint injection. You're putting a needle into the back and then threading a wire up along the spine. And so things can happen, you can have local tissue damage, nerve damage, things like that. It's thankfully extremely rare to have any of those things, but it's always on the back of our mind. Did you optimize everything that's conservative, that's low risk before I send you to that? But I've had some amazing, revolutionary, like life-changing things results with the right person. And so it's just like anything else in medicine. There's always risks, always benefits. You just got to be sure that that's the right treatment for you. This is probably the most exciting part of pain intervention. Pain is neuromodulation is what we call it. So it's an option. You have to go to the right place. You have to go somewhere where they do a lot. Otherwise, your risk of complications is a little higher. But yeah, this is a big passion and love of mine. I mean, all the societies that do this stuff. And if you ever want to talk, come and see me. I'm happy to talk to you more about that.
Great, thank you. And next question, can you talk more about taking gabapentin for spinal stenosis?
Yeah, so gabapentin is interesting. It's funny, like 2 days ago, I gave a talk to the foot and ankle surgeons where they see a lot of nerve pain. And I wasn't kidding when I said I do head to toe. I'm a subspecialist in migraines, and I do about a third of foot and ankle stuff. So I see a lot of neuropathy, and I see a lot of back spinal stenosis. So gabapentin, Lyrica, Cymbalta, amitriptyline, nortriptyline are really commonly used for spinal stenosis. And the idea is that because it's a nerve-related pain where these nerves are getting pinched and they're irritated and they're sending out these electrical signals, the hope is that some nerve pain medicines will help. The problem is it doesn't necessarily bear out in studies where these drugs, you have the side effects and everything else. The response isn't quite as robust as we were hoping. And so you will almost always, as soon as you go in with a doctor's office and you say, I have spinal stenosis, I'm doing physical therapy, I'm doing all this stuff, it's just not working, I still have this pain going down my legs, they'll put you on gabapentin or Lyrica or Cymbalta or Effexor or one of these nerve pain medications. I wish I could say the studies were a lot more encouraging, but the reason we still do it is because a certain percent of people respond really well to it. So if you're one of these like 40% that responds to one of these medications, you took away all the risk of surgery and you got all the benefit for the medicine. So it's worth a try. If I had to have spinal stenosis, I'd at least give each one of those medicines a try and just see if I'm one of the smaller percentage that's going to respond. But I always caution people, hey, this is not going to be a magic fix, but I really would love it if you tried it so that we avoid all the complicated stuff that goes with spinal stenosis down the line.
Great, thank you. Next question. When the nerves are burned, does the patient have a tingling sensation or just feel numb in that area permanently?
Yeah, so when you're burning a nerve, what you're really doing is you're putting a needle in. So let's imagine this is a nerve. I'm putting a needle right next to the nerve, and I'm heating the very tip of the needle right there. And nerves are destroyed once you get past about 60 degrees Celsius, which is pretty hot. And so when we do the ablation, we actually numb the nerves right before we do the burning procedure. And my patients don't feel anything when I'm doing the actual ablation itself. You feel maybe a little warm. Some people have a lot of warmth, and then I just stop, put more numbing in, no problem. So once I numb the nerve and I burn it at usually 80 degrees is what most people will burn it at, you are effectively disabling the nerve. You're not destroying the nerve, you're disabling it. And your body's really good at rebuilding nerves. Even if you cut a nerve, your body does everything humanly possible to kind of reconnect those nerves. So you can't permanently destroy most nerves just with a little procedure. So that's why we say at 6 to 12 months, 18 months, sometimes if you're lucky, those nerves will grow back because that's what your body's job is to make the nerves grow back. And so you won't have permanent numbness. You also won't have permanent pain relief. So if that's the source of the pain, we can get you relief for 6 to 18 months, but eventually it's going to come back and you have to repeat it. That said, it's a little 15-minute procedure. If I can get you 18 months of relief with that little thing, I would take that any day of the week over, a lifelong treatment with gabapentin or, having to send you to surgery or anything else. But if the right thing is surgery, that's fine. But if I can treat it with a simple thing, it's okay.
Great, thank you. And last question, what are your thoughts on dry kneading and how long should the benefits last?
Oh, dry kneading is great. I've had it myself. I have a lot of patients that try it. Dry needling, that we don't know exactly why it works. It's almost like acupuncture combined with a trigger point injection, like I do with my ultrasound. And the idea is that they find like these painful spots and they put these needles in, not quite as deep as I do with my procedure, but not as superficial with acupuncture. And what you're trying to do is trigger those muscles, basically local activation, and trying to induce blood to come through there so that you're healing whatever the issue is right there. It's fantastic. The physical therapists are great at it. And I've seen so many like crazy results with dry needling that I always tell people, hey, if your physical therapist ever recommends it, do it. I have a lot of respect for physical therapists, as you can tell. I think they're fantastic. And dry needling is great. When it doesn't work, though, it's okay. It could still be a muscle spasm that I could help treat. And so, we do the things that I talked about earlier.
Great, thank you. And I see we just had one more question pop in. How often does spinal fusion hardware fail? I had L3, L4 fusion done in January 2021. It did well initially, but then there was some different pain occurring. An x-ray showed that the one rod had dropped. Surgery was done again in October 2021. showed that the set screws on both sets of hardware were loose, so eventually the other rod would have dropped too.
Oh my God, I'm so sorry you're dealing with that. That's terrible. There could be a lot of things going on with that. It's a very sort of individualized thing there. It's not the usual outcome. There's something unusual going on. It could potentially be the way that the hardware is placed. It could be that there's a lot more stress than anticipated, and so maybe you're being really active. It could just be that the bone health isn't quite there to support it. There's so many things it could be. It could just be that it was not placed correctly. That's entirely possible. But surgeons typically are really good at what they do. And so there is a certain percentage of hardware that will fail. It's inevitable when you do enough, but I'm terribly sorry that you're going through it. You should really see kind of go back and see the surgeon or get a second opinion from one of our surgeons here that do a lot of revision surgeries. And it's very, very likely that they'll have you do a lot more testing to make sure that it's not one of these other things that's completely outside of your control. If your bones just will not support the fusion hardware for whatever reason, that's a different story than if the hardware just wasn't placed correctly. And it's so hard to tell just based on the story. But I'm terribly sorry you're going through that. That's super frustrating, especially when you have a big spine surgery and a revision and both of them fail. It's always possible that, something a little more conservative could be helpful, but you really got to see some kind of super specialist surgeon, and we have those here.
Wonderful. It looks like we covered all of our questions here. Thank you again to Dr. V and UC Health for giving us the opportunity to learn about pain management. Thank you to all of those who joined this evening. Our next virtual health series will be on Wednesday, March 9th on colon health. Thank you for joining and have a great rest of your night.
Thanks, everyone.